Approach to parotid swelling. Coming to history, first important, you ask the name, age. Age is quite essential. Like few conditions like recurrent parotiditis of the childhood are common in children, and few conditions like malignancy, they are common in adult age groups. Coming to sex, sex is also quite essential. For example, Sjogren syndrome and a few associated diseases are more common in females and some are more common in men. Then next history is the occupation. Occupation also plays an essential role. A few occupation like people who are exposed to silica or people are exposed to livestock, they have more increased chances of malignancy. Then coming to the presenting complaints, the three major complaints are swelling, pain, and discharge. Elaborating on the complaint of swelling, first the onset, when it started, then the duration of the swelling, whether it is for a long duration or for a very short duration, the mode of onset, progress, any decrease or increase in size. Then whether the swelling is associated with pain, whether the pain is bearable, you need to obviously ask for the VAS score of the pain. Then whether it's associated with mastication, because any colicky type of pain is associated with stones, whether there is any aggravating or relieving factors. These are a few conditions and the cause of pain. For example, benign pleomorphic adenoma, it is slow growing but not associated with pain. In malignant changes, it results in sudden growth and pain is present. Parotiditis is always associated with pain. Parotid abscess is associated with throbbing type of pain. Parotid calculi, it has a colicky type of pain, and especially the pain increases while taking meals. Other important history is history of facial nerve weakness and palsy, difficulty in closing eyes or drooling of saliva is present or not. Then inspection of parotid swelling. First, you inspect in a sitting position. You lift the ear lobule. When you lift the ear lobule, it obliterates the retromandibular groove. You have to inspect the skin over the swelling, whether there is redness present, whether there is any inflammation, whether is there any skin fixity is noted. Then also look for opening of the Stenson's duct. It is opposite to the upper second molar tooth. When you examine an inspection, examine the oral cavity for ipsilateral tonsils. If there is any deep lobe involvement, the tonsils is pushed medially. And coming to the inspection, the site, the 5S is confirmed in any swelling. That is the site, size, shape, surface, and the surroundings. So never forget the 5S of parotid swelling examination. Then moving on to palpation. Palpation tests the mobility by contracting the masseter muscle, and whether when you contract the masseter muscles, how the parotid swelling moves. Usually it moves along the muscle, but at 90 degrees to the masseter muscle, it does not move if it is fixed to the masseter muscle. Test whether it is fixed to the bone. Then bimanual palpation is an important method of examining the parotid gland, which I'll be showing it to you in the next picture. Then skin over the parotid swelling is pinched, whether there is skin fixity or whether the swelling is fixed to the skin is noted. Always look for lymph node. Always look for all the neck lymph nodes, whether any lymph node enlargement is noted or not. On pressing the gland, look for whether the saliva is coming out in the normal gland or blood. I mean, saliva comes out in normal gland and blood comes in malignancy. Then one more important sign which is elicited is the curtain sign. When you move the parotid gland, it does not move beyond the zygomatic arch. Here I will use my laser pointer. Here you can see this is the deep cervical fascia. The deep cervical fascia invests the parotid gland anteriorly and posteriorly. Anteriorly, it forms a parotidomesenteric fascia. So this parotid gland does not go beyond the zygomatic arch. This fascia is attached to the zygomatic arch. So whenever you move, it is limited by the zygomatic arch, which is known as the curtain sign. On examination, these are the things which are examined. The warmth is seen, tenderness, confirm the size, shape, surface, and the extent of the swelling. See the consistency of the swelling, fluctuation, compressibility or reducibility, pulsatile or expansile. Any vascular lesions are present should be, any vascular lesions should be ruled out. Whether transillumination is present in neck swellings like cystic hygroma, they are transilluminant. So rule out any transillumination present. Fixity to is the skin, fixity to underlying muscles, that is the masseter muscle, or the bone, that is the mandible bone, and the surrounding areas to be palpated. So, first, initially, with a single hand, you examine the parotid gland, and here you can see the bimanual palpation. So you need to ask the patient to open his mouth, and you need to one hand should be placed externally, and the other hand should be inserted, and bimanually it has to be palpated. The parotid gland has to be bimanually palpated. Then this is the location of the Stenson's duct. This is just opposite to the upper second molar tooth. So you have to look for any secretion. If there is normal salivary gland, it is usually benign. And if there is bloody discharge, it is suggestive of malignancy. Then coming to the examination of facial nerve. You inspect the nasolabial fold and furrows of or burrows, and it is less marked on inspection if there is facial nerve involvement. Ask the patient to show E in E, that is when he shows E, there is deviation of angle of mouth on the healthy side if the facial nerve is involved. So if there is facial nerve involvement of the right side, the angle of mouth deviates towards the left side, that is on the normal side. And puffing of the cheeks, the paralyzed side bellows out easily on pressing. And if the facial nerve is involved, it also, the patient is unable to close the eyelids on the affected side, and that is the Bell's phenomenon is present. Look for lymph nodes involvement, and look also for the movement of the jaw. So just the summary of my of this examination is, you have to look for Stenson's duct opening, ipsilateral tonsil, fixity to masseter, bimanual examination, facial nerve involvement, and any lymph node involvement. Then little bit, shall I move to the theory part, sir? Little theory after this. Sir? Am I audible, sir?
Yes, tell me.
Yeah, I'll just continue with the anatomy of the parotid gland, sir.
So
let's
do that. Yeah.
Yes, sir. Basically, there are three major salivary glands: parotid, submandibular, and sublingual glands, and there are almost 800 minor salivary glands present. If you see this, if you note this parotid gland, 75% of the parotid gland lies over the masseter muscles. Facial nerves enters the parotid fascia. This is the stylomastoid foramen. It passes between the stylohyoid muscle and the posterior belly of digastric. The stylohyoid muscle is medial and posterior belly of digastric is lateral. It passes between these two muscles, enters the parotid fascia, and there it divides the parotid gland into a superficial and the deep lobe. And coming to the borders of the parotid gland, posteriorly you can see this is the mastoid process. Anteriorly you have the ramus of the mandible. Medially you have the styloid process, the sharp styloid process, which is present medially, and superiorly you can see the external acoustic meatus. So these are the borders of the parotid gland. Parotid gland, they are largest of the all major salivary gland. It is entirely serous in secretion, and it is pyramidal in shape. Coming to the Stenson's duct, the salivary Stenson's duct is 6 centimeter long. It exits from the parotid gland anteriorly. It crosses the masseter muscles, and at the anterior border, it crosses the buccal fat of Pat. It pierces the buccopharyngeal fascia and the buccinator muscle, and just opposite to the second upper molar tooth, it opens. The course of the duct involves a sharp turn at the anterior border of the masseter muscle. And coming to the nerve supply, from the lesser salivatory nucleus from the medulla, the glossopharyngeal nerve exits and it joins the aortic ganglion. And from the auriculotemplar nerve, it also from the that is the mandibular branch of the trigeminal nerve through the auriculotemporal nerve. This nerve supplies the parotid gland. This is the parasympathetic supply of the parotid gland. Three structures pierces the parotid gland from superficial to deep. One is the facial nerve. Next is the retromandibular vein, and this is the external carotid artery. External carotid artery also forms the arterial supply for the parotid gland. Then approach to a parotid gland enlargement. So any parotid gland enlargement, it can be acute or chronic. It can be unilateral swelling or a bilateral swelling. It can be painful or painless. It can be obstructive versus non-obstructive. Obstructive when there is any stones. It can be granulomatous, any disease associated like sarcoidosis, or whether it is non-granulomatous diseases. Then it can be isolated swelling versus swelling with the systemic features. that is any autoimmune disorder is associated with it. Childhood versus adulthood swelling, febrile, whether a patient is having fever or a non-febrile swelling, suppurative versus non-suppurative swelling. Classification of parotid gland enlargement, it can be infective, inflammatory, immune mediated, that is it can be Sjogren syndrome or IgG4 related, that IgG4 related diseases. It can be neoplastic, non-inflammatory, non-neoplastic, and congenital. Coming to unilateral parotid swelling, it can be bacterial, that is superior to peritonitis. Superior to peritonitis usually seen in dehydrated patients after surgery. Most common infection is Staph aureus, followed by Streptococcus viridans. Then next is stones. It causes obstruction, and then it causes infection, that's sialolithiasis. A few points about sialolithiasis is that less than 4 stones. I mean, stones are little less common in parotid gland, more common in submandibular gland. Less than 4 stones, we use something called dormium vasculating. Between 4 to 8 we use lithotripsy, and more than 8 we use endoscopic methods to remove the stones. Then coming to chronic methods, chronic bacterial peritonitis, tumors, stones, and actinomycosis forms the chronic parotid gland swelling. Then the causes of bilateral parotid gland swelling, it can be painful inflammatory cause, it can be either acute or chronic. Then painless non-inflammatory, non-neoplastic swelling, and sialodenosis. So causes of
Shyam,
bilateral.
I think we can now, I think, have
Last
a
two
little
slides, sir.
break.
Last 2 to 3 slides.
Let's have a little break, and then I think we can come back again.
Yes.
So, you see, from the surgical point of view, the most important thing is a unilateral parotid mass. A parotid mass is a lesion arising from a parotid gland from in a localized area. So not when I think if you look at the neoplastic process, it arises in a part of the gland, and then it can grow, either it can grow eccentrically, or it can result in the enlargement of the whole of the gland, right? So generally speaking, there will be a localized swelling arising from the parotid gland. Now, what is the important thing is that when do we say, I mean, any swelling, now remember this word, any swelling, any um, swelling in the parotid region is considered to be arising from the parotid gland unless proved otherwise. So I think this is the most important thing that you have to remember in the context of parotid masses. When I use the word parotid mass, it means a swelling arising from a part of the gland, which may at some point in time become large enough to involve the whole gland. But generally speaking, a parotid mass will present as a localized swelling and not as a diffuse enlargement of the parotid gland. So first is that you should know what is the difference between the parotid enlargement, which is localized parotid enlargement, versus diffuse enlargement. Now for the diffuse enlargement, lot many things Shyam has already covered. Infections will result in the diffuse enlargement, right? Sjogren's disease will result in diffuse enlargement, lymphoepithelial diseases of various types, Paul Mikulic's disease, they all result in diffuse enlargement. And so is a very important entity which is called as mumps, that also appears in a diffuse enlargement. But here we are not talking about diffuse enlargement. Here we are talking of localized swelling arising, or localized swelling arising from a part of the parotid gland. Now, any swelling which is occurring in the parotid region is considered to be arising from the parotid gland. Now, what is the parotid region? That is, I think the surface anatomy of the parotid gland should be very well understood, right? And by and large, you have given a very good depiction of the anatomy of the parotid gland. Importantly, one should be aware that what is the boundary of the parotid region, and there are definite points. You join those points, and then you get a parotid region. Any swelling present in the parotid region should be considered to be arising from the parotid gland. But having said that, there are other swellings also which can be present in the parotid region. Okay. Now, let's say, what are the other swellings which can be present in the parotid region? And are there any specific signs of parotid gland enlarged swelling? are there any specific signs of the parotid mass? There
Curtain
are
sign.
no there are no specific signs of parotid mass. You know, these are all uh, you should know that parotid lymph nodes are also present within the same facial envelope. So if there is swelling arising from the parotid lymph nodes, that also will present like a parotid mass. Get my point? You got my
Yes, sir.
point. So the swellings, these lymph nodes are present in the facial envelope. So suppose a patient has, a squamous cell carcinoma of the scalp. Now this can metastasize to the parotid lymph nodes, and this will exactly present as if there's a parotid mass. Okay. So since it is present within the facial envelope, it will all obey the same things like, curtain sign, as well as, filling up the furrow between the ramus and the mastoid and lifting up the lobule. But now it's important. If you look at all the swellings present in the parotid region, those swellings which are occupying this area between the ramus of the mandible and lifting at the lobule, where the curtain sign is also positive, by a huge majority, all of these lesions will be parotid tumors of one or the other variety. Okay. So what is the message that comes with it? That though other conditions can also mimic, but parotid masses will far outnumber the other conditions. Got my point?
Yes, sir.
So now, are there some, we were talking about a few things. What is the mobility of the parotid gland? If there is a mass lesion in the parotid gland, what is the mobility of it? Now, as we know that parotid is surrounded by a fascia. It has a fascia, deep cervical fascia in this region comes and splits into two and encloses the parotid gland and gets attached to the zygomatic arch. Right. So that's the basic anatomy in this particular region. So that means that there's a facial enlargement, but any swelling which is not infiltrating the underlying muscles, and any swelling which is not arising from the deep lobe of the thyroid of the parotid gland will have some mobility. So there would be more of these transverse mobility at right angle to the masseter, that is the underlying muscle here. There will be mobility in both the vertical as well as in the transverse dimension. But if the swelling is infiltrating, then this mobility will be lost. And second is that if the swelling is arising from the deep lobe of parotid gland, then this swelling presents just like a small bulge on the exterior, on the facial side, and there is an enlargement, or there is a what is called as pushing of the pillars of the tonsils in the oral cavity. Okay, so that's what you should be quite clear about. A few things that you should have said which you have not, and which comes to what are the various signs and symptoms which will kind of suggest that we are dealing with some kind of a parotid malignancy.
Sir,
Now,
fixity to skin, fixity to bone.
now remember, most of these tumors, unless they are infiltrative, will not have any specific signs. Like if the tumor is contained within the parotid gland, it will obey all the laws of a benign swelling.
And
Okay.
ready discharge from the duct,
No,
sir.
listen, no, listen. It will obey all. What we will have is a very a painless swelling which is present for a few months or so. And as we know that in parotid gland, the commonest lesion is pleomorphic adenoma.
Adenoma.
And pleomorphic adenoma can be a slow growing tumor which may be present for more than a year or two, right? So the history would be clear that there is a patient who's got a swelling, who's got a lump in this region, which is painless, growing at a small pace. And you examine this patient and you find this to be a firm swelling, which is having a degree of mobility over the underlying tissues. Okay, so there is nothing, this could be by itself suggest that we are dealing with any kind of parotid neoplasm. It doesn't mean that we are dealing with only pleomorphic adenoma. Now, pleomorphic adenoma will generally be a very benign swelling, and therefore will have most of these swellings, which do not have any uh, uh, growth spurt, or where the pain supervenes, or where the other signs start happening, would generally be indicating towards malignancy. So remember that, by and large, even in the early stages, even malignant neoplasm of the parotid gland will also present like a benign pleomorphic adenoma. Now, what are the things, which suggest that it could be malignancy? Now, this is when the disease starts infiltrating. When the disease starts infiltrating into the surrounding regions, it is clearly going to suggest if it infiltrates the facial nerve, if it infiltrates the pterygoid plates, if it infiltrates the base of the skull, or if it infiltrates the skin, or if there are palpable lymph nodes. Now, these are the things, which will suggest that. Just a minute. Right. So I think we should be very clear that the typical signs of a malignant parotid mass are seen when the disease becomes infiltrative, and infiltration to the facial nerve, that is one, and of course infiltrating to the underlying tissues like masseter muscle, infiltrating to the pterygoid plate, infiltration to the base of the skull, and of course, as we mentioned, presence of lymph nodes, and occurrence of ulceration over the parotid region. So these are the things which suggest that there is an infiltration taking place. So once that infiltration is taking place, most of these swellings will be
Malignant.
malignant swelling. And malignant swellings, of course, there are quite a few of these malignant swellings that we can come to. Okay. Now, are there other things that we need to in the history? Therefore, you should have asked the history of any trismus. History of trismus is quite important, and trismus would generally suggest that the patient is having infiltration of the pterygoid plate, and means that per se the swelling is inoperable, unless of course you planning to do something heroic like base of skull excision, as it is called. So that's a different thing altogether. Okay. Now we have a parotid mass which is mobile, which is present in the which is having a mobility. There is no facial nerve involvement, and there is a slow growing lesion. Now, how do we proceed about what all it can be? It can be a parotid swelling. Could it be something else? It could be a lymph node in the parotid region, as I've mentioned. Could it be something else? Could it be? It could be a lymphoma, and it could it be anything else? Anybody? It could also be secondaries arising from
Brain.
the areas of breast, lungs, kidney are the most common sites from where the secondaries can go to the parotid region. So when you are taking the history, you should also take the history relevant to these malignancies. Kidney tumor will generally present with hematuria. So if your patient has got a history of hematuria and you have to correlate, maybe I think it's a very uncommon for kidney to metastasize solely to the parotid gland, but it can. So as we mentioned, the sites are this lungs, number one, number two, this kidney, breast, and probably the bones. So these are ones, which can metastasize to the parotid gland. And therefore, in the context of any patient, we have to keep that particular point in our assessment. Okay. Now, is there any condition which is which is kind of pre-malignant, or which can result in more cancers in a parotid region? Is there any pre-malignant condition or any condition which can predispose a patient to parotid malignancy?
Recurrent pleomorphic adenoma.
No. Somebody's written Sjogren's? Not really. I think radiation is considered to be one particular entity, radiation in this region, which can predispose a patient to develop subsequently parotid malignancy. And if the patient has received radiation for lymphoma or for thyroid malignancy, I think that history should also be taken. And this can sort of help you understand that whether this patient is at risk of developing malignancy due to a prior radiation exposure. You got my point?
Yes, sir.
So these are the things that one should keep in mind when you are taking the history. For example, if you have a patient with a lump in 70 years old person, what are the possibilities that you would consider? This patient is having a lump in the region of the angle of jaw. It is in a 70-year-old person. There is no facial nerve involvement, and patient is just come for a routine checkup, and you have detected that there is a mass sitting there. What is this likely to be? Anybody? Yes,
Warthin, sir. Warthin, sir.
absolutely right. Now you should be very clear about Warthin's tumor. Sorry. Okay. So what is Warthin's tumor?
Sir, it is parotid congenital. I mean, it is when the parotid duct is present at the normal along the glandular tissue, sir. So when there is a growth, there is a tumor formed. It is more common among smokers. It is also called lymphoepithelioid.
No, lymphomatosum.
Lymphomatosum.
So this is a benign tumor. It has no malignant potential. It is not infiltrative at any point in time. It is very slowly progressive or not progressive at all. And uh, if diagnosed, should you treat this patient or should you not treat this patient? Should you observe this patient? How do you confirm your diagnosis? So this is a tumor in the angle of the jaw, and it is just it has hardly any growth. A patient is 70 years of age. Patient has come to you for the routine examination. You suspect that it could be Warthin's. How will you confirm?
First, we do an ultrasonography followed by FNAC, sir.
What is that you will get from the ultrasound? Is there anything which is specific to this particular tumor? It anybody? It brightly lights up with the technetium scan. Okay, FNAC is a very useful investigation for these patients. And if you are suspecting that it is a Warthin's tumor or it could be a Warthin's tumor, then you can go in for a technetium 99 scan, and it will show up as a brilliantly lit lesion. Now, why are we interested in finding out this particular lesion? Why should we be interested in knowing whether it's Warthin's tumor?
Sir, we have in
Warthin's
this
tumor.
treatment is surgical treatment, sir. You have to remove the
Warthin's tumor can be left alone if patient is not bothered about it, or if the patient is having significant comorbidities, right? Or if the patient is having other conditions. So this is one tumor which can be left alone without anything, and it is very well tolerated. It doesn't interfere with life, it doesn't grow, and can be left alone if the patient is not bothered about the cosmetics, or if the patient is having a high surgical risk. Okay, so this is that's why you should be able to diagnose this tumor confidently and should propose the treatment accordingly. And second thing is that it is one tumor, where the risk of what's called as spillage and spillage resulting in recurrence is very, very insignificantly. Now, why I'm telling you this? If you are looking at pseudomyxum, this
Pleomorphic.
pleomorphic adenoma. In pleomorphic adenoma, if there is a breach in the capsule and there is a spillage of the this spillage of the tumor cells, then it is a possible risk for it's a possible risk
Recurrence.
for recurrence. So whenever we are doing a surgery for pleomorphic adenoma, we have to be very clear that we do not cause any kind of a rupture to the capsule, and we remove it with the margin of the normal gland so that there is no spillage of the neoplastic cells in the field, which is a possible risk factor for the recurrence. Got my point?
Yes, sir.
Remember that. Now, if we have how should we go about? We have taken the history, we have done the examination, and the examination, as you very rightly said, and I think again we can repeat a few points, that you should always look for the mouth opening. You should also look inside the mouth. We should always remember to look inside the mouth and look for the these tonsillar pillars to be moved, which have been moved medially. So there is a dislodgement of the tonsillar pillars towards the medial side. And I am not too happy with the bimanual palpable. In this area, you will not achieve anything in the bimanual palpable. It's a very important observation that you have to move. You have to know whether the tonsillar pillars have become medially dislocated. So that's what you should remember. I think finger examination for bimanual palpation is much more important for submandibular gland. Now, it is also very important for us to remember that when we talk of parotid versus submandibular versus minor salivary glands, there is a formula of 75, 50, and 25. What is that formula?
So, 75% of the tumors are located in the parotid gland, sir. 75, rule of 80.
No, it is not so. Tanushri, she doesn't know. She just put her as.
No, sir.
Huh?
No
So
idea, sir.
the formula of 75 is that 75% of the lesion in the parotid are benign, 50% of the lesion in the submandibular are benign, and 25% of the lesion in the minor salivary glands are benign. So that means that, when you go from parotid to the minor salivary gland, the risk of malignancy increases. That is the formula of 75, 50, and 25. The larger the submandibular, larger the salivary gland, more is the chance that the lesion will be benign, versus the smaller the glands and the more will be the chance that the lesion could be malignant. That is the formula. Okay, so we were talking about the oral cavity, and the oral cavity has had the medial dislocation of the tonsillar pillar, and always looking at the parotid duct, Stenson's duct. And now, one very, very important point is, what is the surface anatomy of the parotid duct or Stenson's duct on the face?
So it is 1.5 centimeters just below the zygomatic bone, sir. It can be palpated on the masseter muscle.
There is a line that you have to draw from the lobule to the angle of the mouth, and part of this line represent, not all of this line, part of this line represent the course of the Stenson's duct.
Yes, sir.
So does anybody remember that surface anatomy of Stenson's duct?
Here it is given.
Show me. It's not. There is a sharp turn that we mentioned, but it is not given the course.
Yes, sir. So one thing I read, it is 1.5 centimeter below the zygomatic bone. It crosses, sir. It is parallel to the zygomatic bone. It goes straight, and then it.
No, this is the thing that you should be very clear about. You can take away this projection.
Yes, sir.
So you should be very clear about one thing, that is the course of this duct, and should be able to feel the course of this duct right up to the anterior border of the masseter muscle, where it turns medially, pierces the buccinator, and opens against the second upper molar, against the crown of the second upper molar. Right. So that is and the course is very important because you can palpate it. But tell me, which is the gland which is more likely to form stones?
The submandibular gland, sir.
Submandibular gland is more likely to form stones, and why?
So because of the kind of secretion, this is more serous, sir, and that is more. I mean, it is less serous and it is more. It is more thick secretions are present in this one, so submandibular gland.
Okay, so that's right. I think submandibular gland is more likely to form the stones, and but parotid gland also does form stones. That it is not that it doesn't form, and it is the contents are serous.
Yes.
Okay. Now tell us how to proceed. Now we have a parotid mass, right? And there, there are no other features suggestive of a possible malignancy. So how do we go about?
First, we do ultrasonography and FNAC to confirm the diagnosis, sir.
So what are the benefit of doing this ultrasonography and FNAC? What is the plus point and what's the minus point? What's the pro and what's the con?
Sir, the plus point is just we rule out malignancy. We come to know the diagnosis of the patient, and an appropriate treatment
You're
is
right. I think if we do the ultrasound and ultrasound guided FNAC, then we can we know exactly that whether we are doing with the parotid gland or we are doing with something extra parotid. So it could be that we are dealing with maybe a lipoma sitting there, or we may be dealing with some kind of a cyst of embryological origin, or we may be dealing with any other lesion arising from the muscle or subcutaneous tissue in that region. Okay, so we can well, ultrasound can very easily show us where is the parotid gland, and from a representative area we can take an FNAC and know for sure what we are dealing with, whether we are dealing with Warthin's tumor, whether we are dealing with mixed parotid tumor or pleomorphic adenoma, whether we are dealing with some kind of a cancer of the parotid gland, or we are dealing with some kind of secondaries, right? So
yes,
it can, or secondaries from whichever region, or whether we are dealing with a lymphoma. For example, lymphoma is also known to occur in the parotid region, parotid gland. And if there is a lymphoma from the parotid gland, surgery can be definitely avoided, and one can go in for what's called as chemoradiation or chemotherapy alone. So these
yes.
are the things that we can do for these patients, and that will be important to establish the diagnosis. So FNAC for parotid gland swelling has so many things going for it, right? And ultrasound and FNA together can pinpoint whether the lesion is from the parotid gland or is from some kind of a extra parotid source, which we have just enumerated. Okay. What is the negative side of FNA?
Sir, the one thing which we
बता दिया मैं
fear
सही
is
मंगवा
feeding.
रही हूँ यहाँ पे
Once again, I'll just mute.
Please, Srishti, please mute.
Yes, sir. Sir, आपको आप unmute करना है. Yes, sir. So the one thing which is feared is seeding of the tumor cells, sir.
So seeding of the tumor cell is possible only in cases of
Yes, yes.
what we call as if we are doing with the true cut needle biopsies, with the current needle biopsies which we use. And what is the number of the needle that we use these days?
24
aspiration.
24 coach, sir.
22, 20, I think 22, 24, 26, depending upon, but I think by and large 22 is the one that they generally use. But I think we can cross check it. I think when I last reviewed the subject, probably 22 was the one that I found out. But I think I stand to correction if somebody can correct me. So you do an FNA with a 22 needle, and what do you do in that? How do you do FNA?
So using ultrasound guidance, you go to the, I mean, wherever there is a swelling, you insert the needle. Then through vacuum suction, you just suck the cells, and then
No,
you take the
no. So you put the needle inside the parotid gland, then apply
negative
vacuum,
suction
apply vacuum or apply pull out the
piston, sir.
plunger, and then pass the needle into 2 or 3 different areas. So you go at right angle. You don't withdraw the needle to come outside the skin, outside of the disease, outside the parotid gland, but you advance the needle in different directions, right? And keep on applying the pressure on the plunger. Once you have done that and you are trying to come out, that's the time you stop the pressure on the plunger so that no blood gets sucked when you are outside the gland. So you know that you have to apply the pressure at the time when you are inside, you are passing the needle into different directions. Once you have done that, 3 or 4 passes are done, then you stop doing the pressure on the plunger. You stop the pressure on the plunger and come out without, vacuum being present at the time when you are withdrawing the syringe. So that's very important. If you don't do that, then the blood will get sucked in and it will become useless investigation. So you should know exactly how to do a proper FNA, and you must see how it is done. Okay. So what is the negative side? There is no risk or very low risk of needle track seedling after this particular procedure. Initially, it used to be considered, but that was when large needles were used and when people were not very clear about the process. Now, if you know the process and the way I have explained to you, I think the risk of FNA resulting in needle track seedling is very low. There are a few conditions, where this FNA is considered to be still a no-go area, and that no-go area is
Vascular
test.
lesion, sir.
Huh?
Vascular lesion, sir.
Vascular is a separate thing. I'm talking of neoplastic lesion. So in testicular tumor, it is still considered to be no-go area, a complete contraindication. But parotid has ceased to be a contraindication. Now, what are the disadvantage of FNA?
Distortion of plane, sir.
Distortion of plane? No.
Sir, in acute infection, it is contraindicated, sir.
We are not talking about. We are talking about this.
There is acute abscess or acute infection.
Yes. What did you say?
In acute infection or abscess, inflammatory phase, it is contraindicated, sir.
We are not talking about it. We are talking about a parotid mass. When we use the word parotid mass, it means a lesion which is not inflammatory. Salivary gland histology on FNA can be fraught with many misrepresentation or misinterpretation. So there are very few people, and very few experts who can give you a very confirmed diagnosis of the type of malignancy on FNA. And it is also very clear that whenever there is a parotid mass, it needs to be removed unless there is a contraindication for whatever reason to establish the diagnosis and also cause the treatment. Right?
Yes, sir.
So whenever there is a parotid mass, you know that ultrasound has shown that it's a parotid mass. Now you know exactly if it is in the superficial lobe, what you have to do. If it is in the deep lobe, what you have to do, you know that. So FNA is, in what way FNA is going to help us? But others say that if you have the diagnosis of malignancy pre-hand, let's say that I know that I am dealing with a common malignancy here is
Mucoepidermal carcinoma.
mucoepidermoid carcinoma. Then there is this
Arsenic cell carcinoma.
Adenoid cystic is the next one. Squamous cell is another one.
Acidic
Then
cell
actinic
carcinoma.
cell is another one. Then the new entity secretory is, tumor of the of the parotid gland is another one. So there are quite a few of these malignancies, and the one that I've forgotten is uh, carcinoma X pleomorphic adenoma.
Hmm. Yes,
So
sir.
these are the ones you know, and they say that if you know that the diagnosis prehand, then maybe you can simultaneously do lymph node dissection in high risk situation straight away, right? Or if you don't want to take the approach of FNA, then you can do a frozen section. And if you find that you are dealing with a malignancy of a aggressive nature, then you can go and do a lymph node dissection, even if lymph nodes are not palpable. So that is a prophylactic lymphadenectomy, which is needed for patients of parotid malignancies of aggressive nature. And of course, if we talk about all of those things, we hardly have any time left for that. But let's see, we can keep on talking a few things in the meantime. So these are the flip side of it. The plus side we have already discussed, but the flip side is that if there is a misinterpretation of the specimen, then you are nowhere. And second is that whatever is the lesion, it needs to be excised, right? It's only, as we mentioned earlier on, that if it is Warthin's, in some patients it can be left alone, and all others would need to be removed. Right. Why do we
Yes.
need to remove? Why do we need to remove a small pleomorphic adenoma? Let's say it's a 2 centimeter lesion or less than 2 centimeter lesion. Why do we need to remove it?
There is always a small risk of malignancy in pleomorphic adenoma, sir.
Anybody else? You are not wrong, but you can be better. Yes, Muhammad Mustafa, Sushila Chaudhary. I'm happy that there are some new names here, and it's good. Malignant transformation. That's of course, malignant transformation is a possibility which happens in about 6 to 10% of the patients of pleomorphic adenoma. I think when the tumor grows larger, it becomes, a higher risk factor for the damage to the facial nerve. So if you remove a tumor which is smaller, the risk of injury to the facial nerve is less. So if you have a diagnosis of pleomorphic adenoma, better to remove as soon as you have diagnosed it. You get three benefits out of it. First is the risk of facial nerve involvement. Second is, uh, better cosmesis, right? And third is, of course, you're obviating the risk of a subsequent transformation to malignancy in 10% of the cases. So diagnose it and chop it off. Okay, so that's what we wanted to discuss today.
So
We
the
can,
last two slides are there. Shall I finish it, sir?
yeah, just let me complete it. I'll let you to complete all of those 2 slides. I thought that we should give some clinical perspective to your talk.
Yes, sir.
When would you like to go in for that? Now we have understood, the need for doing FNAC and ultrasound. When will you like to do a CT scan or an MRI?
Yes, sir. CT scan or MRI, there are clear indications, sir. One, if there is involvement of the deep lobe, if the size of the tumor is more than 3 centimeter in size, then it is a solid. If it is a solid tumor, sir, then
All patients where there is a trismus, where there is a where there is a large tumor, you're right, and
recurrent disease, sir. Recurrent disease and if there is any involvement of the bone or the nerve, sir.
yes, you're right. So repeat it. I think you have got all of these things correct. So when would you like? It's a large tumor, deep lobe tumor, recurrent disease, facial nerve involvement, bony involvement.
Bone involvement, yes.
So these are the things, where you would like to have a clear understanding, and all of these things will be important from the point of view of planning resection. As you know, the treatment of parotid malignancies is basically surgical. Second treatment that works out in some situations and can help to control the disease is radiation. But radiation per se, without reducing the bulk of disease or without removing the gross disease, is just a palliation. If you want to cure the disease, you have to excise. And if you are still not able to have an R0, at least R1 resection is done in all the cases, all the gross disease that can be removed is removed, and subsequently you can achieve a greater disease control with radiation. So whenever there is a, if you look at TNM staging, and let's say what is a T? T1 is 2 centimeter or less. T2 is 4
2 to 4.
centimeter. 2 to 4 centimeter. T3 is
more than 4 centimeter.
More than 4 centimeter, and T4 is
Involved with the mandible, skin, sinus.
Yes. So all T4 lesions would need to be examined or need to be understood in terms of their overall, extent, the areas that they are involving by way of a CT scan. And as you know, CT is an important investigation for bony involvement. And if you want to know the involvement of the soft tissues in that region, so you get better information from MRI. So depending upon, if CT scan gives you all the information that you need in the planning, that's fine. Otherwise, you can go in for additional information by MRI. So all of these things will help you understand the extent of the disease and then plan the treatment accordingly. So this is what I wanted to contribute to this class. And now I leave it to Shyam to complete the last 2 slides of his presentation.
Yes, sir.
Before you say that, I think 3 important surgeries that you should know about. One is superficial parotidectomy, other is total parotidectomy, and third is radical parotidectomy. You should read from your book and have a concept. And in case you have any doubt, or if you seek any clarification or clarity about it, you can always talk to me. So 3 surgeries are the keystone for treatment of parotid disease. And again, a bit superficial parotidectomy, total parotidectomy, and total parotidectomy. When you're talking about total parotidectomy with nerve preservation, and total parotidectomy with sacrifice of the nerve, and last but not the least, extended parotid resection. Now, if you want, I can just complete it by just adding a few points here. Superficial parotidectomy is removal of the superficial lobe of the parotid, which is the common site for most of the benign lesions and also for the most of the malignant lesions also. This surgery is done in the plane, fasciovenous plane, where we remove every part of the parotid superficial to the facial nerve. Okay, so that is superficial parotidectomy. It is done in the fasciovenous plane and in front of the facial nerve. The other is total parotidectomy with nerve preservation. When you remove, when the lesion is in the deep lobe, to approach the deep lobe, we have to first remove the superficial lobe and then mobilize the nerve. And from under the nerves, we remove the deep lobe of the parotid gland. That is parotidectomy with nerve preservation. And then the third, parotidectomy with sacrifice of the nerve. Only when the nerve cannot be saved and when it is infiltrated is the nerve sacrificed. Nerve is not sacrificed liberally. It is only sacrificed in few situations when the tumor is involving the nerve or infiltrating the nerve. And if it is infiltrating one trunk or one branch, only that branch should be sacrificed. And last but not the least, if you have sacrificed it, you should also reconstruct the nerve by a cable graft there and then. Okay, so that is total parotidectomy. And what is extended parotidectomy? When you do the parotid removal of the parotid with extra parotid regions or extra parotid structures. Like if I'm removing the base of the skull, if I'm removing this pterygoid process, then it becomes extended resection. So extended resections can also be done. If the nerve can be saved, it should be saved. Total parotidectomy doesn't offer any additional benefit if the same can be done with the superficial parotidectomy. Important thing for you to remember is removal of the disease with a margin of the normal tissue. That's all there is to it, whether the disease is malignant or whether it is mixed parotid tumor. Okay. So now, Shyam,
Yes, sir.
fast.
Yes, coming to chronic, painful, less painful inflammatory bilateral parotid gland swelling. This is caused by Sjogren's syndrome, chronic granulomatous diseases, sarcoidosis, tuberculosis, leprosy, cat scratch diseases, granulomatosis with polyangiitis known as Wegener's granulomatosis, IgG-related diseases and IgE-related diseases, chronic viral diseases commonly caused by paramyxoviruses and Coxsackie viruses, and recurrent parotiditis of the childhood. Chronic painless, non-inflammatory, non-neoplastic bilateral parotid gland swelling. It includes amyloidosis, diabetes, acromegaly, myxedema, gonadal hypofunction, Cushing syndrome, eating disorders, and rarely pancreatitis. Bilateral parotid swelling with dry mouth and dry eyes. The most common is Sjogren's syndrome. Sjogren's syndrome, you have to do an important test called Schirmer's test, where you have a filter paper in the lower part of the eyelid and look for secretion. The others is like sarcoidosis, amyloidosis, and IgG4 related systemic diseases. This is a systematic way when you approach the parotid gland swelling. When you suspect any inflammatory disease process, you do an ultrasound, and there is
we
any
have
solid
discussed
mass.
it. I think we can move on.
This we have involved. And again, indication of CT and MRI already discussed, that is deep lobe tumors, large tumors more than 3 centimeter, congenital parotid mass, recurrent diseases, and any feature suggestive of malignancy, that is facial nerve involvement and fixity to mandible, that you have to do CT scan and MRI. Thank you, sir.
I was not in the best of the condition after having had a very hectic day, but I thought that since we have started this program, we must continue having this program without any break. So I think Shyam is pushing me and I'm getting pushed. I'm happy.
Yes, sir.